Now we have a surgical approach of acquired heart disease. This is the acquired heart disease involved a valvular heart disease, ischemic heart disease, cardiac trauma, and cardiac tumor. We will mention in details about each one of that, the indication for the surgery and the type of surgery for each of these pathology affected of the heart. As you remember in your anatomy, there is two types of the valves, either on the left side or on the right side. The left side, it is a high pressure valve. This is, we have a mitral valve and aortic valve. And the low pressure, we have a right side valve, tricuspid, and pulmonary. All the three parts have three cuspid. Only the mitral valve have a bicuspid. The main causes of the valvular heart disease, especially in our country, due to the rheumatic, and beside that, a degenerative myxomatous degeneration of the valve cusp. Yes. Yeah. Okay. Beside that, hello. دزيت الصوت دزيته. شكرا استاذ مؤيد. الو. Now, the mitral valve disease. The etiology of that one, it is mainly aromatic heart disease due to the repeated tonsillitis in early age. And this is a repeated tonsillitis. It will be by the heart, or it can attack the kidney or even the joint. So always be careful about the rheumatic fever, and it should be treated in aggressive way to prevent in the future to develop our mitral valve disease. Second one, we have a degenerative leaflet degeneration, or maybe have annular dilatation, or sometimes you have a functional mitral valve regurg due to the non-organic. Severe mitral valve stenosis. When you have a severe mitral valve stenosis, what will happen? It will lead back pressure on the pulmonary veins, and will be affected on the pulmonary circulation, and it will be, by its way, it will be affected on the tricuspid valve. It reads what we call a functionally tricuspid regurg or incompetence. So the clinical feature of that one, it is, I think it is taken in the medical side. It leads pulmonary venous congestion and low cardiac output and high pulmonary venous pressure. And when you put your stethoscope, you hear a murmur, and mainly it will be affected of the atrial fibrillation. This is a serious thing. Now, as you remember, the size of the mitral valve it will be affected by the size of the patient, and the gender of the patient, either male or female. It will be normally from the 4 centimeter to 6 centimeter square. It will be the diameter of the mitral valve. When it will be reducted of this size, it will have the start of the complaining and severity. As you remember, by medical side, according to the classification of a New York Heart Association classification, and it will be either stage 1 or stage 2 or stage 3 or stage 4. When we have a stage 3, if this patient is put it on the waiting list for the surgical intervention for dealing with mitral valve stenosis. In the case of the stage 4, it will be early put in the list of the waiting patient for the intervention. Now, what type of the intervention we can do it? Previously, we can do it by closed mitral valvotomy. This is when we use by left thoracotomy, no need for bypass machine. No need for extrapulmonary circulation. Only we can do it on the normal beating heart. Normal beating heart. We do a left thoracotomy in the fourth intercostal space, and we will look then percutting on the left atrial appendages, and also we can put a small incision in the left ventricle apex, and we inserted a TAPS dilator. TAPS dilator. This is a TAPS dilator. TAPS dilator. I put my finger in the left atrium, and it will be guided the TAPS dilator to read the mitral valve. After that, I will be open this TAPS dilator. It should be always when I open it, it only to 2 and 0.5 to 3 centimeter, not put it more, to prevent any complication post-operative. It will be lead to the mitral valve regurg, which is a more serious than the complaining of the mitral stenosis. This is a TAPS dilator. We do it in the open heart surgery. In open heart, impeding, it's not in open heart. It need no need for the cardiopulmonary bypass. It is on beating heart. Okay. Second things, now they try to do it a percutaneous balloon mitral valvotomy. They go through the right atrium and make some hole in the septum of the ASD, a septum of ASD, and go through it, go to the left side of the atrium and go to the mitral and make balloon dilatation for that one. And after that, we close the ASD by umbrella. Or maybe you need an open heart surgery, a bypass machine. When it is a surgery of the left side, as you remember, left side of the surgery, it need only a partial bypass. Only on the right side of the heart, it need a total bypass. As you remember what we mean by partial or total, a partial mean it is only to put a single venous cannula, and in the total bypass, it need to put a 2 cannulae to complete evacuated of the venous drainage from the superior vena cava and inferior vena cava. Now, when we do an open mitral commissurectomy, this is always we do it in the young age, especially in female in age of the pregnancy, to prevent any complication of the anticoagulant or a valvular, either it will be a mechanical valve or a tissue valve when it needs a replacement. Always we keep it a commissurectomy, or maybe sometimes we do a ring annuloplasty to the support the annulus of that one, especially when we have a mitral valve prolapse, especially of anterior cusp, not a posterior cusp. The most important in mitral valve, it is anterior cusp. It contains 2/3 of the size of the mitral, and posterior cusp only it took 1/3 of the diameter of the size of the mitral valve. Or maybe you need a mitral valve repair, that I do a repair for that mitral valve. And lastly, maybe it need when have a severe damage of that valve, it need what we call a mitral valve replacement. Here, the most important during the surgery should be the surgeon be careful about the circumflex artery, because it is nearby the cusp. When it is a severe calcified cusp, when I resected this cusp, maybe I go more deep on the wall. Maybe I will be injured the circumflex artery. Now, another valve we have aortic valve disease, either aortic stenosis or aortic regurg. Either it will be a congenitally aortic valve stenosis, or maybe it is a rheumatic heart and disease, or maybe a degenerative one, or maybe you have a tertiary syphilis. It will be affected of the mitral aortic valve, or maybe trauma lead to the rupture of cusp of the aortic valve, or maybe subacute bacterial endocarditis. It lead to the damage of the valve, especially when you have this valve, it is a bicuspid, not a tricuspid. Or maybe have a Morphan syndrome. This is a Morphan syndrome. It is a long, taller person with the high palate arch, with the high and taller one. This is what we have in Morphan syndromes. Now, always in aortic valve, the clinical feature of that one, clinical feature, the most serious one when you have aortic stenosis. When you have aortic stenosis, the diameter of the aorta, when it is increased below zero point 0.8, it is a seriously a fatal outcome of that patient. Should be put it in early list of the surgery to do a replacement of the aortic valve. An agonist of aortic regurgitation need for life. Now, it is why it is in aortic stenosis, it need an early intervention, not like in the aortic regurg. Yani, put it in your mind, why? Because the coronary artery, only the artery, it took blood supply during the diastolic phase. All the organs, all the vessels supply, all the organ of the body, it took a blood supply during systolic one. Except coronary circulation, it took a blood supply by diastolic. So when you have a severe stenotic one, there is no diastolic volume to supply a myocardium, and this is a seriously one. It leads to the sudden cardiac arrest, a sudden death. Replacement of that in children and infant, always we can use an autograft. The autograft, we took a pulmonary valve inserted an aortic valve, and the pulmonary one we inserted for them a homograft. Why؟ يعني سؤال يقول لي ليش ما نستعمل رأسا homograft؟ No, because the pulmonary valve, it will be a native tissue. It will be increased in size by the growing of the patient, not like the homograft. It will be increased in size by during the growth of that child. Pulmonary valve, it is an always stenotic. Rarely it is an incompetence. And stenotic, maybe need a valvotomy is applied. Previously, in 1980, we can do it by the close, what we call it, inflow occlusion surgery. What is an inflow? Inflow occlusion surgery. I will put the patient, I make a sternotomy. When I go make a percentage on the pulmonary artery above the pulmonary valve, I make a stay suture. After that, I go and make then a tape band around the superior vena cava and another one on the inferior vena cava. I told the assistant to stop by the occlusion of the both superior vena cava and inferior vena cava. Any flow to the heart, it will be zero. The heart, it will be arrested. There is no inflow. Immediately, I make an incision on the pulmonary artery above the pulmonary valve. Immediately, I make then dilatation by the scissor, or by scalpel. After that, take the procedure only 1 minute. Only 1 minute. Assistant to release the occlusion of the superior vena, inferior vena cava, and I make an exclusion clamp on that incision at the start to suture of the pulmonary artery. Tricuspid valve disease, usually functional, as I mentioned, because of the mitral valve stenosis. It leads to the functionally tricuspid regurg or incompetence. may be affected by the organic disease, by organic disease. Sometimes I don't know why. Till now, they don't know the cause. And we have only the tricuspid valve disease, only this valve. There is the other three valves, it is an intact. This is found in the drug addiction, especially when this drug addiction, it is injectable, not by inhale. They found that one, tricuspid valve disease. Till now, they don't know why. Only the injectable drug addiction lead to the tricuspid valve disease only. Operation, it is always by annuloplasty because it is a right side valve. It is a low pressure. Always a precaution. Don't do any replacement. You should be repair it. You should be repair it. You should be repair it. And valve replacement now, we have two types of the valves. Either biological valve, what we call the bioprosthesis, divided into a biological one. An autograft, we took a valve from the same patient. Or homograft, we took it from another species, and from human to human. Or a xenograft, this is from another species. This is we took it either from the bovine or pig. This is we do a valvular replacement, a valvular replacement. Now, what is the advantage of the biological than mechanical one? First of all, it is less thrombogenic, yani no need to use for long life anticoagulant. No systemic anticoagulant needed. We keep this patient for 3 to 6 months post-operative or anticoagulant, and after that, no need for to give anticoagulant. When we use this one, when we have an old age, a life expanse of that one, maybe 10 years or below, we can do it. And especially in hemophilic patient, or sometimes patient, he prefer, but I need this biological, I'm not need a mechanical one. And disadvantage of that biological one than the mechanical one, it is low durability. It only, it will be damaged after 8 to 10 years. It should be do a replacement of that one. Maybe due to the degeneration, perforation, fibrosis, or calcified. Mechanical valve, not one. Previously, we have many types. In early era of the mechanical valve, they discovered it. They put it now because of the technology of that one. They make another similar to the native valve, what we call tittling disc, or maybe have. Why this is a use now? Because it's durable. It will be continue for more than 25 to 30 years or more. But the problem here, it is a thrombogenic because of foreign body, so it need anticoagulant. And you should be keep it and receive on the oral anticoagulant like the warfarin and INR should be 2 to 2.5 of is normal. Complication of that, because of the foreign body, a mechanical one maybe have a liability for infection, liability for thrombosis if it is a PT and INR it is low, or we have a PT INR it is high more than 3.5, it need to the bleeding, or because of the mechanical one, maybe due to the embolization, showing of the emboli. Always don't forget. I always repeat it on that one. Left side, you can use a mechanical mechanical. Right side always use a biological. Maybe on the left side, if the patient he prefer, we can't do a biological. But on the right side valve is always a preferable. It is a biological one. These are the types. These are type. Type C, this is what we call ball and gauge. And this is a type, type C. This is a type A. This is what we call it titling, titling one, Sanjuit, and at the previous هذا Sanjuit in A. الوان that's the green one we call it بيجورك. الA زين will be هذا the green one. This is what we call it البيجورك, and this is ball and gauge. And that one D1, this is a tissue valve. We have many tissue valve. This is now wait we have valve. Then this is Sanjuit. This is a tissue one. The most important now in your practice, it is ischemic heart disease, obstruction of the coronary artery. If you remember by anatomy, coronary artery and right main coronary artery, that it will be blood supply for the left side of the heart and right side of the heart. And it should be blood supply, it will be sufficient at least when the physical or emotional exercise. If there's any need to the insufficiency of that demand of the blood, it lead to what we call it an angina. Now, it need always to do it. Either we do a PCI, percutaneous coronary intervention, or maybe use a CABG, coronary artery bypass graft. Now there is many rules always between the medical and surgeon, the cardiologist and cardiac surgeon. This they said it should be indicated to do a CABG, and that one indicated to do a PCI. The type of the graft we use it, this is it should be inverted يعني inverted Savinus vein, or maybe use internal memory, lima, left internal memory artery, or maybe you can use a right internal memory artery, rima or lima. We can use both of them. We can use lima and rima, or we can use a radial artery, or we can use a gastroepiploic artery from the stomach. These are the best replacement for the artery is an artery. Second choice, it is for the replacement of the artery, it is a venous one. For always we prefer an artery for artery. Now, an ischemic heart disease, we have, first of all, normal indication of the CABG when it is affected of left main coronary artery. Second, when it is affected a proximal part of the LAD, left anterior descending artery, and the ostium of that one. This is also indication for the CABG, always preferable. Now there is a conflict between a surgeon and cardiologist. They need to do a PCI stent, but always I prefer to do a CABG for them. Third one, when you have a triple vessels affected, it need to do a CABG for them. CABG of them. Now, sometimes we need an emergency CABG. First of all, when we have a complication of ischemic heart disease, like we have ventricular septal defect, related to the myocardial infarction. Second, when we have a papillary muscle ruptures lead to the mitral regurg, or maybe lead to the left ventricular pseudoaneurysm, or we have a free wall rupture, or we have a life-threatening ventricular arrhythmia. Six, when we have a cardiogenic shock. I will repeat it for you. When you have a ventricular septal defect, when we have a papillary muscle rupture, or we have a free wall rupture, or we have ventricular pseudoaneurysm, or life-threatening ventricular arrhythmia, and lastly, six, it is a cardiogenic shock. Sometimes we use a cabbage for symptoms improvement. That when we have a significant stenosis and unacceptable angina despite of medical therapy, or we have a significant stenosis and unacceptable angina in patients with the medication contraindication for adverse effect of this patient. Yani the patient, he can use this medication. This is always preferred to do a surgery for them, or a good candidate for cabbage and consider over the PCI when they have a complex three vessels. We mentioned that one. Now, always, 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 we do cabbage after failed PCI. Sometimes we do a PCI for them. I do a cabbage for them. When it start, first of all, ongoing ischemia or a threatened occlusion. Second, when hemodynamic compromise without impairment of the coagulation. Third, hemodynamic compromise with the impairment of the coagulation. That one without impairment, that one with impairment of the coagulation, or hemodynamic compromise and the previous sternotomy and emergency cabbage may be considered in this one. These should be put it in the failure of PCI when there is sometimes a fracture of stent, or catheter inside the coronary. We do a surgery, and during the cardiac PCI, the cardiologist they يشتغل in the crack or rupture of the stent, and in a proper position, it need to do a surgical for them. These are the type how we do it. This is the type what we do it. Either we do it on beating heart or off bypass, and off beating heart, patient either off pump or with pump. لو تخلي المريض على الماشين باباتي على cardiopulmonary machine, or we can use it especially when have a single valve and single vessel disease. We can do it on beating heart. This is the term we call it pump off or pump on. Pump off it is a beating heart. Pump on معناته on cardiopulmonary bypass machine. Now, cardiac tumors. The most important of cardiac tumors, we have myxoma. This myxoma, it is a benign tumor. The main location of that one, it is the left atrium. Second, maybe in right atrium. Maybe third part in the left ventricle, or fourth part maybe in the right ventricles. This type of the myxoma either sessile or pedunculated. Sessile, yeah, they have no pedicle, or pedunculated have a stump, and this is either it will be involve the septum or it is not penetrating of the septum so deeply, either superficial embedded in the septum or deeply embedded in the septum. The criteria of that one, it looked like a mitral valve stenosis. And presentation marathon, it looked like mitral valve stenosis. And more seriously, when we have showing of that thrombi of this tumor lead to the acute limb ischemia due to the embolism of this cardiac tumor. Or maybe go to the central valve. It lead to the vessels. It go to the cerebral vascular accident, lead to the CVA of that one. The surgery of that one always should be by open bypass machine. And it should be on the bypass machine. When we open that one, we open the left atrium, we can always cut part of the septum to prevent any recurrence of that tumor. If the defect of that septum it is a large, we can put a patch to close it. This created the ASD. But it is a small one, we can close it directly by suturing of that defect in the septums. Last thing, we have a cardiac trauma. Cardiac trauma, we have many types of cardiac trauma, either blunt, like the RTA, steering wheel trauma. It leads to either contusion of myocardium. This is, we can know by doing cardiac enzyme, ECG change, and by echo, it will be discovered, it will be to ischemic of that one. Or maybe you have by the cardiac tamponade due to the trauma. And this cardiac tamponade should be, because this is an acute tamponade, not a chronic one. And the drainage of the tamponade by many methods. Either we do it pericardiocentesis by subxiphoid insertion of the catheter under ECG monitor or echo monitor. Or maybe have a penetrating cardiac trauma. It need to do an exploration. Either we can do it on the off bypass or on bypass machine. الهارت transplant it should be have a donor and recipient. When you take, it should be have the same blood group, and it should be HLA-B a compatibility, and should be have after that immunosuppressant of this patient to prevent any rejection of that one. We can use azathioprine, cyclosporine A, or corticosteroid. This is the procedure we do it. We took it in the left ventricular assistant device. I hope that, sorry for the first a few minutes that not hear my voice, because this is my fault. I've not opened the mic. Sorry for that one, and thank you for your listening. I hope that you enjoy with these lectures. Thank you for you. Bye.